Hello, everyone. Good morning. I want to welcome you to the third webinar of a six-part series on opioids in the hospital, addressing inpatient harm. My name is Michelle Bonson, and I serve as a clinical quality consultant on the Compass HIIN team. For those of you on past webinars, welcome back. And for those of you joining for the first time, thanks for joining us today. The goal of this particular series is to provide you with standardized and evidence-based approaches to reduce inpatient adverse events related to opioids. Today, we will spend our time talking about best practices that support safety. We have a couple of brief housekeeping items to cover before we start our session this morning. I'd like to ask that you please take a moment and check your phone lines or computer audio and make sure you are muted. We appreciate your attention to this as it does help us avoid background noise during our session. We also ask that if you need to step away from the session today, please avoid placing the call on hold so we don't have your call waiting background music playing during our webinar. We expect that you will have questions as we move through the session. Please feel free to utilize the chat box throughout the webinar to type in questions as they come to mind. If you haven't already done so, please set your chat to all attendees and panelists. This will allow all on the line with us today to see your comments and questions. If you would like to speak during our webinar, please utilize the raise hand symbol and we will unmute your line to allow everyone to hear you. Lastly, this session will be recorded and transcribed. This might be a good time to remind everyone that prior recordings can be found on the Compass HIIN YouTube channel. The location is noted on the footer of this slide. Before we get things underway, let's take a few minutes to go over the agenda. After a brief welcome and introductions, we're going to recap last week's session. Then we'll spend some time, I guess it's really the majority of our time, reviewing best practices as it relates to decreasing opioid-related harm in the inpatient setting. And lastly, we will close with next steps. I had the opportunity to introduce myself, so now it's your turn. We sometimes have the same people on these calls, which is absolutely great, but sometimes we have new people as well. So just take a few minutes, type in your name, your organization, and your role or title. And one other thing, where would you go on vacation if time and money were not an object? And please do that in the chat box. And if you haven't already learned this about me by now, I like to start with some virtual social time before we dive into the content. I do this because it helps us connect when we aren't in the same room. And quite honestly, discussions around opioids can get heavy at times and very in-depth. So I think it's good to just start with a little bit of social time. So go ahead, enter your name, your organization role, and where you would go on vacation if time and money were not an object. Ooh, I like the idea of Italy, Kate. Ooh, we have a lot of people wanting to leave the United States. Awesome. Tanya, let me see here. I love it. I bet you there's a place we could find. I think Hawaii might be close to that, Tanya. Ooh, Venice, Australia, Europe, awesome. Well, I will be honest with you right now. I would love to be in London. That's where my daughter is for the summer, and she is studying there, and I've never been there, and she's just having the time of her life. So that's what I would do if I were able to this summer. Thank you so much for sharing, everyone, and welcome. As previously indicated, this is the third of a six-part webinar series. You will note that the schedule includes a one-week break during the week of July 1st because we know this is a busy travel time for many of you. Portions of the series may be comprised of a mix of presentation and work time, so we might run a little less than an hour so you can have some work time to complete some tasks associated with the current or past webinars. And I want to reinforce that I understand your time is limited and that many of you wear many hats, more than one hat typically. So I hope you find this helpful as we move through the sessions. I can't promise that this will be the same way every webinar, but it will be when it makes sense and when the topic allows for it. After this webinar, we'll be halfway through the series. And so I have asked my fellow clinical quality consultants to reach out to the hospitals they work with who are on the call to see how things are going and to see what, if any, additional assistance you might need. I know at times it can feel sort of awkward using the chat, so please know I welcome your emails. I would love to hear what you're learning and doing with this information, and would also like to get a feel for who might be willing to share their experiences during the last webinar of the series. I promise it will be painless, and if public speaking is not your thing, let's get creative on how to share your message. It's so important that we do that because all of us may be doing different things that are really beneficial, and it's important for cross learning. Just a gentle reminder here, following this session and actually every session, registered attendees will receive an email with a link to the recorded version of the webinar. And if you have a peer that didn't register but is curious about attending future sessions or would like to catch up by viewing prior sessions, please reach out to your clinical quality consultant for guidance. During the second session of the series, which was recorded, and I thank you all for accommodating that. I was not able to be here in person, as you know. There was a review of what it takes to be successful when it comes to QI work, how we need to engage our frontline staff and have the right people working on the right things, and is applicable to their responsibilities and or passions. After that, we moved into the importance of environmental assessment, sometimes called scans, to identify the what, who, when, where, and why relative to opioid use in the inpatient unit or units within your hospital. This could include procedures, order sets, naloxone use monitoring, including a root cause analysis, staff thoughts about opportunities, scales, and or assessment protocols. The group was asked to complete an environmental assessment, and you all received a tool to help guide you through it. And using the chat box, let me know how your assessment went. Did you find any gaps? Did you encounter any barriers? Did you start to think about opportunities where you might be able to run the PDSA cycle? Feel free to share away. And I just want to add that if you didn't get it all completed, you can continue to work on it, as this week we'll be talking about some best practices, and you may be able to benchmark as you continue to gather your baseline data. Not seeing anything in the chat yet. So I don't know if that means you didn't have an opportunity to get started, if you're still absorbing it, if you're still sort of contemplating how you want to answer. Well, let's go ahead and move on. And in the interim, feel free to know that this is sort of an interactive session, even though we're using chat. So please go ahead, and if you feel like you want to enter any comments relative to that or any questions, please do so. And before we continue on, I just want to pause for a moment to see if you have any questions or comments as it relates to what we've covered thus far in the first two webinars. All right, I think we have a kind of quiet group today. I'm not seeing anything, so we will just continue on. Before opioid therapy is initiated, whether it's in surgery or non-surgical settings, real or potential risks of respiratory depression or other opioid-related events should be identified. The what, the how much of an opioid should be carefully scrutinized. Frequent monitoring for adverse events should take place and be completed in accordance with your policies, procedures, and protocols. Last, but certainly not least, is education for staff and patients. They are vital to reducing harm. I want to apologize in advance for this very busy slide on opioid-induced respiratory depression risk factors. I would probably get a failing grade if anybody were to review this. I think there's supposed to be 3 bullets to a slide, but if you can believe it, I actually slimmed this down and condensed where I was able. Some are pretty self-explanatory, but some are worthy of more discussion. So I will pause a moment so that you can peruse the list, and then let's plan to go a little deeper into the details and some of the tools that coincide with assessing risk. I'd just like to point out as well as you kind of peruse the list that Lexi has kindly put a link into the chat for the slides. If you did not get those via email, you didn't have access to your email prior to this webinar. And I think that Dino did the same. So we're covered there. So please feel free to go ahead and pull up the slide deck if you'd like at any time. Obstructive sleep apnea, also referred to as OSA, is a common condition that is characterized by periodic obstruction of the upper airways during sleep or excessive sedation and may be partial or complete. It's one thing to contend with known OSA, however, more than 3/4 of patients are undiagnosed. In the perioperative period, patients with OSA have higher incidence of respiratory depression and episodes of hypercarbia, hypoxia due to sedating medications, including anesthesia and opioids. Medical patients with OSA are also at higher risk for respiratory depression and respiratory arrest in the presence of opioids. They might start out alert and then fall asleep when not observed. They become apneic and die within a very short time frame. This is why sedation scores alone are not sufficient, as the patient may be awake during a nurse assessment but fall asleep quickly in the absence of stimulation. Identification of these high-risk patients allows for more frequent monitoring. Let's talk a little bit about that monitoring. So sleep studies are the gold standard for evaluating OSA. Unfortunately, this is really not a cost-effective or time-efficient type of screening tool for all patients presenting for care at the hospital. It may be beneficial to perform a sleep study prior to a planned surgery or admission if there is a high degree of suspicion of OSA, particularly if there is a large operation planned. This would allow for post-operative continuous positive airway pressure needs. Patients who have a CPAP at home should be asked to bring them to use during their hospital stay. So a quick question for all of you. How many of you assess for home CPAP use in your admission planning or admission assessment protocols? Great, Brooke. You assess. Perfect. Barb, you don't use that as part of inpatient admissions, okay? Tanya, you do that, okay? Okay, great. Yep, for surgical patients. Thanks, Barb. Barb, did you, I see your hand is raised. Did you have a question you wanted me to allow you to talk for a moment? Oh, okay, no problem, no problem. Okay, since we know that a large portion of patients live with undiagnosed OSA, screening preoperative patients for possible OSA is important as it really relates to guiding inpatient pain management and monitoring. Let's take a closer look at 3 of the screening tests that are used. The first one is the Stopbank tool. It's a simple to use assessment that is widely used in the preoperative arena. It consists of 4 and 8 questions respectively. The stop portion of the questionnaire consists of 4 yes/no self-answer questions assessing snoring, tiredness, observed apneas, and high blood pressure. And the bank portion of the questionnaire adds clinically observed pieces, again with yes/no answers, including BMI, age, neck circumference, and of male gender. Positive answers on 2 of the 4 questions of the stop or 3 of the 8 questions for Stopbank indicate high risk for sleep apnea. The study has been validated and demonstrates high sensitivity with moderate specificity, which means it tends to overestimate the likelihood of OSA in patients. This particular tool was designed to be self-administered by the patient, which is good because it is a relatively simple tool. Having said that, what would you want to consider before handing this over to a patient to complete? What are your thoughts on that? Just some considerations, and go ahead and enter those in the chat box. And really, this is applicable to anything that you might hand over to a patient to complete. That's great, Joan. You're right. Yep, that it's a screening tool and not diagnostic. Great. You guys came up with things that I didn't even think about. So it's kind of, if you're going to be utilizing this, you probably need to have staff that and the availability of tools to be able to do the BMI, maybe measure that neck. The other thing that I was thinking about as I was going through this was thinking about health literacy. Literacy in general, and disabilities that are not obvious to the administrator. So some persons may have reading difficulty, maybe they don't have their glasses, whatever it may be. And perhaps further definitions or examples of snoring loudly or daytime tiredness might be needed. So for example, when you ask, do you snore loudly? Some people may say, well, I don't know, I don't hear myself. So really it's if they're loud enough to be heard through closed doors, or perhaps the bed partner elbows you for snoring at night. Yep, great, Amanda. That's all great input, everyone. So the second one I'm going to talk about is the Berlin Questionnaire. It's a widely used tool with good validation, but it lags a little bit in sensitivity when you compare it to Stopbank. This was originally designed for the primary care environment, but it's also used in the acute care setting. This tool requires more calculations based on categories related to snoring, daytime sleepiness, and a history of hypertension or obesity, so a little more time consuming than Stopbank. The tool and the scoring methodology are embedded in this slide for your reference. And so you can come back to this at any time and take a look at it. So again, a little more time required to complete this one due to the calculations. And the last tool we're going to discuss today is the UpWorth Sleepiness Scale, which is geared toward evaluating for excessive daytime sleepiness. It's a simple and self-administered tool as well, which makes it an efficient method for pre-op evaluation. Its sensitivity is significantly lower than the others we reviewed, as there's a high degree of subjectivity, and so it may be better used as a companion assessment to another tool. You will note there is variability in the scoring depending on the source. Regardless of the scoring, the key takeaway here is that a score of 10 or greater suggests the patient may be at high risk for OSA. Of these three, which one or which couple does your institution currently use? Some of you may not know the answer to that. Some of you may. Oh, Stopbank. Yep. Very popular. If you aren't sure what your institution uses, it might be just good to have that information, just so you can have that as part of your environmental inventory. My mom was recently screened prior to a surgery, and this was the tool that they used. And if not stated earlier, the use of a tool in the perioperative period is necessary and actually simple, quick, and cost-effective. Tools with higher sensitivity should take precedence over those with a better specificity to identify patients who are at risk of OSA related to respiratory depression. Are there any questions anyone has before we move on? Okay, I'm not seeing anything in the chat box, and I'm not seeing any raised hands at the moment. So I'm going to go ahead and continue on here. While OSA is the #1 risk factor for opioid-induced respiratory depression, there are medical conditions and diseases that have the propensity to increase the risk of post-operative drug-induced respiratory depression and other opioid-related adverse events. Let's spend some time reviewing these and also some non-respiratory opioid-related adverse events. For reference, the blocks with the blue or darker font represent the non-respiratory events. Morbid obesity, which is categorized as a BMI greater than 35, contributes to the development of OSA, which, when combined with opioids, results in increased apneic episodes. Obese patients may also experience hypoventilation syndrome. And so, given these risk factors, consideration should be given to treating with non-opioid therapy or closer monitoring when administering those IV opioids or combination of opioids with other sedating medications. Pulmonary disease and heart disease probably don't need a lot of detailed explanation because we know that poor perfusion and inadequate oxygen exchange are directly correlated with respiratory complications, and these are heightened during opioid therapy. Renal disease and liver disease are a little trickier due to the way in which certain medications are eliminated and metabolized. In renal disease, metabolites are not eliminated as efficiently. So those patients with renal impairment, morphine and meperidine are the most problematic, followed by hydromorphone, and lastly, fentanyl. While the safest, fentanyl has a rapid onset and short duration of action, which may prove to be difficult to dose depending on the situation. All opioids are metabolized by the liver, so if a patient presents with mild liver dysfunction, it's not usually a cause for immediate alarm. However, in patients with severe liver failure, each dose of an opioid may have a longer duration of action and more potent activity. A way to counteract the risk is to either decrease the dose, widen the time between doses, and if that's not possible, make sure you have additional monitoring in place. That will be required. Patients with chronic pain are at risk for difficult to control acute pain. They may require higher doses of opioids due to tolerance. They frequently experience continued pain in the face of respiratory depression. And we know that long-term use, misuse, and overuse of opioids does not result in immunity from opioid-related respiratory depression, and thus the reason for expanded access to naloxone outside of the healthcare setting. And I know that's not part of our topic, I guess, per se. We're really focusing on in the hospital, but I just wanted to speak to that a little bit. So using the chat box, what are some ideas or thoughts you have about managing patients with chronic pain, either before or during the course of their care at your hospital? What are some things that you think, maybe it's interventions or actions that are important? Maybe it's things you already have in place. We talked about increased monitoring. We have a very quiet group today. Oh, here comes Tanya. Great. Yes, I agree. Good conversation and realistic goals. That's really important. That's that whole patient and family engagement and involving, yes, involving that pharmacist. Yes, exactly. I think the other thing that is really important for these chronic pain folks who are on opioids at home is just really having early identification. So, if possible, pre-hospitalization inventory of use of prescribed or non-prescribed opioids. And I know that not all of you, due to the size of your hospital, have a pain specialist available, but if you do, a pain specialist consult may be very beneficial. And then, of course, you already hit on all the patient and family engagement pieces. The purpose of setting apart discussion of substance abuse and mental illness from the prior slide is twofold. Patients with either or both, number one, I guess I should say, patients with either or both have a right to appropriate pain management. We always need to remember that. And number two, there are some unique or special considerations and or risk screening tools that may be appropriate. Persons with mental illness may have exacerbations of anxiety, depression, or other symptoms of mental illness when opioids are withheld. They often have pre-admission anxiety, which may result in increased opioid consumption to manage the effects of the anxiety. And lastly, persons with a mental illness are at higher risk for comorbid substance use disorder. Opioids alone may mask or mimic mental illness, so emphasis should be put on a thorough history, and consideration should be given for an early psychiatric consultation to aid in the development of an appropriate treatment plan. Some screening tools that may be used for these folks are a patient health questionnaire for depression, which is the PHQ-9, a generalized anxiety disorder assessment, the GAD-7, and of course a thorough H&P and or thorough review of the medical record for mental illness diagnoses. Patients with current or past history of substance abuse pose a really unique challenge with regard to pain management. I would like to emphasize that immediately following a serious illness or major surgery is not the time to initiate any form of drug detoxification therapy. And as I stated earlier, all patients have the right to pain management. However, this does not mean they are privy to a certain agent or route of administration. So I know that sometimes that can get a little precarious, but know that you and your team and your medical team do have the right to determine what agent or route of administration is beneficial. And I think a couple of key things that may be beneficial as you work through risk are a careful history, use of an opioid risk stratification tool, which is the ORT, a urine drug screen at the time of admission for those with known or suspected substance abuse, and a query of the PDMP or the Prescription Drug Monitoring Program database for historical and current prescriptions. Are any of you on the call today actively using the PDMP, or in Iowa it's referred to as the PMP, in any capacity as it relates to opioid prescribing? And if so, in what capacity or in what area are you utilizing that? So I see some ED use there, the clinics, the hospitalists, greater regional. Yes, you're using it as well. And this is not surprising to me, and I anticipate that for those of you that maybe are just sort of starting it or don't really have a clear processes in place, you will probably, because of the mandated use of the PMP for some prescribing activity. Great, Barb. If you would like more details or examples about any of the tools that I just covered, the depression screening or the opioid risk tool, please use the link at the bottom of the slide. It will take you to those tools. Just a few more things to touch on before we move into safe prescribing and administration. Persons who exhibit drug-seeking behaviors may be disruptive to their own care or others' care. I know that you encounter this at your hospitals. Some of examples of those behaviors include bringing opioids from outside of the hospital or having family or friends bring them in. Maybe they're hoarding medications. They might try to tamper with PCA pumps and possibly even injecting oral opioids. This is, of course, not an exhaustive list, but some practices to combat this, including setting clear limits. You might need to institute a behavior contract. You might want to consider setting your hospital policies around the appropriate indication for IV opioids, which would include order sets. And then creating an analgesic plan to avert staff splitting or manipulation. So it's something that you could all follow and reinforce with that patient. And lastly, I want you to be aware that neurologic conditions or delirium may require additional attention to pain management due to possibly an inability to understand how to use equipment such as a PCA. Dose reductions or change to non-sedating medications may be necessary as you work to control the pain while balancing the increased sensitivity to the sedating effects of opioids that this particular patient population encounters. And poorly controlled pain may result in inefficient and dangerous dosing to gain control, and we'll talk a little bit more about this later in the webinar. Okay, I just saw a question here. I was just going to ask if we had any questions or not. And Tanya asked a question, is it being considered to have nursing have access to the BMP? And Joanne was right on that. And you are right, the guidelines are to have up to 6 staff to assist providers, and nurses can be on those lists. So yes, the answer is yes. Thank you for helping each other out. That's what I love about these types of webinars and about the Jumpstart, helping and learning from one another. Thank you for your participation. I greatly appreciate it. I would like to set the stage for the next section of today's presentation, which is safe prescribing and administration. And I want to be sure to touch on the additive sedation risk from non-opioid medications when combined with opioid medications, including identification of the drugs that fit into this profile. After that, we will dig a little deeper into actual prescribing and dispensing safety. It's not uncommon, as you know, for patients to be on one or more sedatives while in the hospital. Some patients continue a regimen they use at home, and some may be using them as a multimodal approach to help reduce opioid escalation. Regardless of either of those, the important takeaway is that staff is aware of common sedating medications and that increased monitoring protocols are in place and used accordingly. Benzodiazepines used alone mildly sedate the respiratory system. We know that, and evidence supports that when combined with opioids, there's an increased synergy, kind of like chocolate alone and peanut butter alone, but when you put them together, look out. I guess you can tell I have Reese's peanut butter cups on my mind. Remember way back at the beginning of the call, I alluded to the fact that opioid discussions can get a bit heavy. Well, that was my intent to lighten it a bit, and please know that I'm not attempting to diminish the impact of the combination, as it has been linked to numerous cases of fatal respiratory depression. So it's not to be taken lightly, but I just wanted to throw a little something different in there for you. Just a few other points relative to this slide. Antidepressants may or may not contribute to increased sedation depending on the class. Muscle relaxants will always have a sedating effect and may be more sedating when combined with opioids, particularly in patients who are elderly or naive. Evidence of increased sedation with opioids and anticonvulsants or gabapentinoids is limited, but it appears to be trending in that direction. These medications are used and should continue to be used as part of a multimodal pain regimen, particularly due to evidence that supports the opioid-sparing analgesic effect of perioperative use of gabapentinoids. Ketamine, clonidine, and oh boy, I'm going to need a pharmacist for this one. Dexmedetomidine, I think I got it right. Multimodal agents that are used in isolation or as adjuvants to decrease opioid consumption. Data continues to evolve relative to multimodal pain management. As such, I would really encourage you to speak with your pharmacist and or your medical teams for additional information on this topic and how it's being incorporated at your hospital. If there's something that we all know, opioids and treatment and alternatives and awareness evolve every day. So I think it's important to stay connected with those in your hospital that are working on keeping up to date with all of this information. There are some terms that we've used and that we'll be using as we further discuss prescribing and administration. So I think we need to just discuss those briefly or touch on those. So opioid naive are patients who are not chronically receiving opioid analgesics on a daily basis. Those that are opioid tolerant are chronically receiving opioid analgesics on a daily basis. And multimodal, I think we talked about this a couple of presentations ago, but it's using 2 or more different methods or medications to manage pain rather than using opioids alone. I think it'll be a little easier to discuss prescribing and administration best practices if we address the opioid naive patient separate of the opioid tolerant patient, as each will have unique considerations. The preferred route for administering opioids for those opioid naive patients is orally whenever feasible, and times when it's not feasible include the immediate postoperative period of pain, or if pain is unpredictable or rapid, or if the patient is not able to take a medication by mouth. IV opioids commonly used are morphine, hydromorphone, and fentanyl, while oral includes morphine, hydromorphone, oxycodone, and hydrocodone with acetaminophen. This is not an exhaustive list, and it's highly encouraged that hospitals have a preferred drug use or a preferred drug for use as first-line treatment, whether it's oral or IV. Consideration should be given to the advantages and disadvantages of each, including the doses available, the age of the patient, and the frequency by which the pain medication is ordered and or requested. This is particularly important when considering whether a PCA is warranted or if the patient may be better suited on a scheduled or PRN analgesic. I think it's important to point out that PRN orders may not be adequate for patients who require pain treatment in advance of a procedure or activity, as they may have mild pain prior to that event, and as such would not meet the criteria for a pain medication that is indicated for moderate to severe pain. This is where you may want to consider having orders for anticipated pain and documentation to support this. Short-acting PRN opioids are preferable for opioid-naive patients, as sustained release may result in overdose as acute pain continues to improve. This is particularly important as patients prepare to discharge with an opioid prescription. And of course, our goal would be to have patients discharge without an opioid prescription if at all possible. But if they do need to, you need to give careful consideration to what they're going home on. Studies have shown that patients may experience better pain relief via the use of multimodal analgesia versus using opioids alone. And there are several drugs and techniques used within this framework, and I would venture to guess that some of your hospitals have already incorporated this or are considering it. Some examples include acetaminophen in moderate to large doses around the clock, NSAIDs, lidocaine infusions, ketamine infusions, intrathecal or epidural injections or infusions, peripheral nerve blocks, and gabapentin. Patients should be assessed and reassessed according to your hospital's policy, and best practice includes using a comfort scale in lieu of a pain scale. We talked a little bit about the comfort scale before, assessing how pain impacts their function, monitoring for side effects and adverse effects, and whether or not there is relief. The reassessment time should coincide with the peak effect of the drug being administered. For simplicity, it may make sense to assume a peak effect of 30 minutes for all IV opioids and 1 hour for all oral immediate release opioids. Reassessing risk too soon may result in redosing and dose stacking if the pain is not yet controlled, and if done too late, significant respiratory depression may be missed. We briefly touched on that comfort menu before, and this is a very important and sometimes underused tool that may negate the need for initial and or ongoing opioid administration. You may access the comfort scale and comfort menu using the link at the bottom of this slide. I encourage you to take a look at those if you haven't before, but I think a lot of you have had the opportunity to see those, whether it's during another presentation, during our opioid guardianship, through your clinical quality consultant, but please take a look at those and think about how you might incorporate them. Before we move on, how many of you have policies around assessment and reassessment of pain? And I guess kind of beyond that, how many of you audit for compliance? So does your audit findings, if you do audits, do they show any correlation between the use of naloxone and the timing of reassessment? This may be an opportunity for your hospital, particularly if you are experiencing increased opioid adverse events. Just going to pause here for a second to see if anybody wants to comment on that. Again, we're looking to see how many of you have policies around assessment and reassessment of pain or protocols, and if you audit or not for compliance. And there's no right or wrong answer. This is an opportunity to sort of think about how you might address inpatient harm. Hi, Joanne. Is there a form that could be followed for this or a protocol? I will look into that for you. Okay. Greater Regional has a policy to assess and reassess pain. So Brooke, is that okay, let's see here. Joanne, okay. Great, Tanya. So you already have sort of that built-in hard stop to go ahead and do that. Brooke, I have a question for you. Is that a policy that you would be willing to share with the larger group, or do you need to check into that first to see if that's a possibility? And we can always discuss that offline if you need to take a check with others in your organization to see if that's okay or not. Okay, great, Brooke. Thanks so much. I appreciate that. And I will also, Joanne, I'll also take a look. There's a lot of materials that I've been looking through as I prepare for these presentations. And so I feel like I saw something, but I definitely will take that as a takeaway and follow up on that as well. A very large section of the guide that is the basis for this Jumpstart focuses on the opioid tolerant patient. and rightly so, because they present with unique needs and management that is typically more complex than that of an opioid naive patient. Having said that, I want to reiterate how important it is that your hospital spends some time educating staff, engaging your entire care team, enlisting the assistance of your pharmacist, and very importantly, engaging the patient and their family, as they have a great deal of history that may provide you with some advantages relative to the treatment protocol you will implement. In all honesty, I think this could be a topic on its own. But due to the amount of ground we need to cover in the next several sessions, I will do my best to hit the high points. And then I want to encourage you to read more about this as part of your homework. Please feel free to use the link at the bottom of the slide to access the guide that I referenced. You will find additional detail on pages 43 through 53 if you want to write that down. So at a high level, the most important factor in determining what drugs and what dosages to use in this population when they experience acute pain is to determine their home dose, their home use, and most recent usage pattern. Don't forget, this may not always be apparent in their medical record alone. You may need to seek information from alternative sources such as the outpatient pharmacy, maybe past prescribers, the PMP, family and friends. Establishing a safe environment free of judgment may assist with obtaining the most accurate information from the patient alone. And please always ask them what they may be taking that has not been prescribed for them. So, what medications are you taking, but what medications are you taking, or what are you using that maybe has not been prescribed by your physician or healthcare provider. Patients on a verified regular dose of a sustained release opioid should have it continued if at all possible to avoid withdrawal. If a different opioid is used, 30 to 50% of the equianalgesic dosage should be ordered to account for any tolerance. If the patient is on a fentanyl patch, you should remove the existing patch and place a new one to ensure dosing intervals are maintained during their stay. Asking the patient should be the first line of inquiry relative to the existing patches, and a skin assessment should be the second line. This approach allows you to assess for any skin pressure injuries that were present on admission as well. So you're sort of killing two birds with one stone. Patients on methadone or buprenorphine, please set clear protocols for your staff. I can't emphasize this enough. Encourage your pharmacist and a prescriber to assist with creating and updating according to the evolving evidence. There are some special considerations for these medications as they relate to pain management as well as addiction maintenance. Clear delineation between the two is necessary. Again, this could be a whole topic on its own. So I encourage you to read more or speak with your pharmacist if you're looking for additional information about what your institution is doing. And there's no simple calculation for determining an acute dose of an opioid in an opioid tolerant patient. Please know that it may be more than double of the preoperative daily use, and you really need to consider lower threshold for PCA use in this patient. So in other words, for the opioid naive, you may not use a PCA, but it may be important to use for this population. And so as we talk about PCA, we know that the use is a little bit controversial. I know several of you are moving away from any PCA use. It has been useful in patients with a history of substance abuse. However, the opioid tolerant patient may be more difficult to transition off that PCA. And when it's used, a good strategy to move away from the PCA to oral might be to taper the PCA dose or increase the lockout interval over a few days. And then when the usage has moderated somewhat, you might convert to a reasonable oral dose. And you should also consider the use of a loading dose prior to that PCA use. Lockout intervals should not be shorter than 10 minutes. However, staff should be aware and in tune to shorter intervals that are used as a catch-up after surgery and address any concerns immediately before continuing with the shorter interval. You need to carefully titrate according to your hospital protocols. Like the opioid naive patient, opioid tolerant patient benefits from a balanced multimodal approach and non-pharmacologic interventions. Engage your pharmacist with development and maintenance of safe opioid conversions, whether developed in-house or provided in an electronic application. Assessment and reassessment policies, we kind of talked about that already, and policy and protocol should really address the same things we discussed earlier when reviewing the best practices for the opioid naive patient. Be sure to include any additional requirements or unique requirements for this population. There are some special safety concerns for patients who receive opioids from multiple sources simultaneously. So it's important to be cognizant of multiple sources used at once. Think about infiltration of opioids around wound or in joints during surgery, as they'll be absorbed over the first 24 hours. Epidural and intrathecal infusions frequently contain opioids. Absorption and clearance from the epidural space can vary significantly. So if at all possible, consult a pain physician with questions on how to safely manage that. Know that transdermal patches are delayed in onset from time of application, and heat will enhance the systemic concentration by up to threefold. So that may be intentional heat on the patient's part, or it may be unintentional heat. Transmucosal fentanyl has a very rapid onset. It's very potent and should not be used in opioid naive patients. Increased routes, increased dosages equal increased monitoring. And we'll talk a little bit more about monitoring as we move toward the end of the presentation. Oh, okay, that was a hunk of material, wasn't it? So feel free to drop your questions or comments in the chat. I'm hoping to leave enough time at the end to address these, but I think I didn't take into account all the amount of material I have here, so I'm kind of cruising through it a little bit. If there are questions that we don't get to, please know that I will answer them in a follow-up email. And if you've been sitting down for a long time, stand up, take a quick stretch, and let's settle back in for the final topics for today's session. We're going to move into education now, and I really like this quote. I think it sums up the circle of learning. You know, learning requires capacity, ability, and willingness. And this is so true for all of us in the medical industry. A knowledge deficit alone could be the reason opioid-related adverse events happen in a hospital. So what to do about it? Well, acknowledge and address it. Find a physician champion or another respected individual in your institution to assist with communicating on opioid safety gaps and discuss tools that will help with closing gaps. Lean on your institutional knowledge, including frontline hospitalists, your pharmacists, anesthesiologists, and nurse anesthetists to assist with educational materials. But I want to remind you that education alone is really not sufficient. It must be supplemented with bedside alerts and other tools, facility leadership at the helm to support the change and define expectations. And another highly important piece, remember to measure and assess the effective interventions put into place. Your QI team should engage providers in education seminars and lectures to identify and come up with methods to address gaps. Let's take a look at a few approaches to address knowledge gaps. Here are some ideas that might work at your hospital, or maybe you're currently implementing them. I like the idea of making your opioid-related adverse event initiatives visible. What a fantastic way to promote patient and family engagement. I also like the idea of incorporating learning during other learning times rather than feeling like one more thing to do. What is not listed on this slide is how important it is to disseminate information about your quality initiatives at medical staff and nursing staff meetings, weaving this in with other topics such as readmission rates, other adverse events, patient satisfaction, value-based purchasing initiatives will assist staff with gaining knowledge and having opportunity to provide their input and feedback. What you don't know how to improve. Medication management in the hospital is a complex process, guys. I understand that. And the goal is to decrease variability and improve patient safety. This is often achieved via standardized policies, protocols, and procedures. All relevant parties must be involved. And so why is this? Well, we've talked about it before. Why do we need to have other people involved? Why should it not be developed in a box by one person? If it's not developed across a multi-level committee, which basically means there's diverse input, it probably won't create buy-in, and now you're back to square one. The key to create less burden and more autonomy or less restrictive pieces are to decrease the chance for workarounds. Excuse me, I need to restate that. So the key is to create less burden and more autonomy, making things less restrictive if possible, because this will decrease the chance for workarounds. There, I got it out right. So let's face it, workarounds happen. We know that. And as such, you should be reviewing your policies and procedures on a regular basis and evolving them as your hospital and or best practices evolve. So you'll see that's why I have on the slide, crossing out Plan A, crossing out Plan B, you might need Plan C. And one last thing I want to touch on relative to something that provides a level of enhancement to education is the use of clinical decision support systems and computerized physician order entry, which I know many of you do. I would venture to guess that you all have these, and when developed correctly, they create efficiencies, effectiveness, they decrease variability, and provide alerts to things that fall outside of the norm. Effective pain care and patient safety rely on vigilant 24-hour bedside nursing assessments for opioid adverse events. This includes vitals, pain or comfort level, respiratory quality and effort and sedation levels. CMS's guidance includes a requirement to educate the family and patient, preferably using teach-back relative to the need for frequent monitoring, and to encourage them to be alert to concerns relating to breathing problems or other reactions that may be related to medications. They also require that nursing staff are trained in early detection and timely intervention when a patient experiences respiratory depression or oversedation. Earlier, we discussed the timing of initial assessments and how they should coincide with the times to reach peak effect. Reassessment is highly variable depending on each patient situation. There's really insufficient evidence to recommend the routine use of capnography for monitoring for hypoventilation. Many organizations endorse continuous pulse oximetry, and the utility of such has been proven to be pretty effective. There are some limitations to its benefit. Can any of you identify what that might be? So what are some limitations you think to using pulse oximetry? And for the sake of time, I'm just going to kind of throw up there. Yep, perfect. Great, Amanda, that's right. What about alarm fatigue, guys? Both in clinicians and patients, right? So we know that clinicians experience it, and that results in complacency. And then sometimes the patients, they get tired of all that beeping and the noise and the things that go on, so they might just decide to remove it. They might decide to be non-compliant with it. So kind of think about that too. There are several sedation scales available for nursing assessment, including the Richmond Agitation Scale, the Ramsey Sedation Scale, Comfort Scale, and the one I want to go over in more detail is the Passero Opioid-Induced Sedation Scale. Some of you are probably very familiar with this, if not all of you. And when compared to a number of scales, the POS scored higher in ease of use, nursing confidence, and usefulness of information for clinical decision making. As you look at this slide, you can see it's fairly self-explanatory relative to assessment and intervention. Which scale or scales does your hospital use for assessing opioid-induced sedation? If you don't know, this is an opportunity for you to become educated on that. Okay, so a little more homework for you all. If you don't know, I would encourage you to find out what scale your hospital uses. Just a brief reminder, references for today's materials were included in the footer of select slides when applicable. And the reference on this slide is the tool providing the framework for our Jumpstart. It's been the same one that I've had on every presentation. Before we wrap up, I want to thank you for your time. I'm trying to keep it to time here. We're going a little bit over. I apologize that. I also want to let you know that you can reach out to me anytime via email. I know it's not always easy to throw things in the chat, and you're hearing things and you're trying to process things. So I would love to hear from you to see if anything we covered up to this point has resulted in an aha moment, what it was and what you're planning to do with it. And homework for the next week includes continuing with your environmental assessment and start to think about some gaps that you might have. Cross-reference the best practices we discussed today to identify those gaps. And that might be some good information for you to consider as you look at the possibility of doing a PDSA cycle. All right. It's a wrap, guys. As usual, you will receive an email with links to this presentation. If you have any questions per our next webinar on June 25th, which is a Tuesday rather than our usual Wednesday slot, please feel free to reach out to me or your assigned clinical quality consultant. And please, everyone, have a great week and have a wonderful weekend. And thank you so much for joining today.